This week on the BackTable podcast.
I think that this is going to be the disruptive technology, in my opinion. I think it's going to let us know when to be more aggressive, when to be less aggressive. But even we're starting in an era for non-muscle invasive bladder cancer where this technology may have the capacity to identify some of the mutations associated with the tumor and tailor the treatment for the patients as the trials are coming. And that could have a huge impact in the patients, and it's most likely going to provide us better outcomes in the long term.
Hello everyone, and welcome back to BackTable Urology, your source for all things urology. You can find all episodes on Apple, Spotify, YouTube, and on BackTable.com. This is Jose Silva, is your host this week. Today we have Dr. Alberto Pieretti. Dr. Pieretti is an urologic oncologist at Cleveland Clinic Weston Hospital, specializing in the surgical management of genitourinary malignancies. He completed his residency, his general surgery internship and urology residency at Mass General Hospital and Harvard Medical School. And then afterwards, he went and did a urologic oncology at the University of Texas MD Anderson Cancer Center. Alberto, welcome to BackTable.
Thanks, Jose. This is a great pleasure to be here with you and to spend some time to discuss about bladder cancer and the emerge of circulating tumor DNA.
Excellent. So like you mentioned, today we'll be diving in bladder cancer, just an overview where we are today in terms of diagnosis, monitoring, treatment, and then dive a little bit or just mention a couple of things in terms of where we're heading. And like you mentioned, Circulating DNA, ctDNA, which is something that it's new, revolutionary. So, Alberto, let's start with bladder cancer. Let's see right now in terms of ctDNA, where we're at.
Yeah, so ctDNA is being FDA approved. A lot of practices and academic practices already integrated ctDNA in their algorithm to work up and follow up their patients. There is, if you go to PubMed and you look for the amount of publications that have emergent ctDNA, the trend has actually been quite impressive in the last 2 to 3 years. And it is actually right now something that is a very hot topic because it has the opportunity to change the way that we stage the disease, the way that we follow the disease, and it, to some degree, may change the indications for treatments for some of the patients.
Excellent, yeah. So like you mentioned, bladder cancer right now, it's we've seen it every time more and more. I remember when we were residency, it was like the number 8 most common cancer in men. Now I think it's number 4. Are you seeing more non-invasive, muscle-invasive? What are you seeing more in your practice?
Yeah, there is a lot of bladder cancer that we're currently seeing. I think in general, the ratio is 80-20 between non-muscle invasive bladder cancer and muscle invasive bladder cancer. In my practice, because we are a referral center, probably that ratio is more to muscle invasive bladder cancer because that's when the patients get referred to us for the possibility of neoadjuvant chemotherapy, radical cystectomy, or to evaluate the patients to see if they could get bladder preservation. So our ratio could be a little bit higher than the regular community, but I think for a national rate is, around 75-80 for non-muscle invasive bladder cancer versus 20-25% for muscle invasive bladder cancer.
And can you give a review just for the residents out there and the PAs listening to the podcast? What are the type of bladder cancer?
Yeah, so one thing is the histologic component, and the most common one is what we call the urothelial carcinoma. And then we broadly divide bladder cancer in non-muscle invasive bladder cancer, which is kind of in the superficial layers of the cancer, and in muscle invasive bladder cancer, where it's embedded into the muscle layer. We call it T2. And it's kind of scary because that's when the risk of spreading and metastasis could increase in a significant way. In the non-muscle invasive bladder cancer, we use several factors to stratify. One is how the cell looks, if it's high grade, if it's low grade, the level of invasion, if it's TA, T1 into the lamina propria. And then we use other factors as, is it only located in one area? Is it multifocal? What is the tumor size? And if they have other risk factors like CIS or a variant histology, which may label this pain as a poor prognosis. And in some of them, we're actually more aggressive, even if they're non-muscle invasive bladder cancer.
And in terms of risk factors for bladder cancer in general and some of the symptoms, I remember back in residency, we talk about textile, for patients that work in textile, rubber industries, smoking, very important. But now I'm seeing more non-smokers. Are you seeing that also in your population?
I think as a general basis, I see still a lot of patients who at least were former smokers or that they were having secondhand smoking, which is still a huge risk factor. So smoking continues to be the biggest risk factor for the development of bladder cancer. There are other chemical exposures in that dyes, textiles, rubbers that could increase that. And then now with the revolution of genetics, we actually, not to a huge proportion of them, but every day we see more patients that have genetic conditions that predispose them to form like bladder cancer, urothelial carcinoma, like Lynch syndrome. Again, it's not like we're seeing that every day, but we're identifying those patients more frequently with genetic testing nowadays.
We'll put a parenthesis right now. I mean, in terms of Lynch syndrome, what patient would you recommend or who you would tell, hey, tell your family members about this, they need to be tested for this?
Yeah, so, today we're talking about bladder cancer. Like if I see patients with upper tract urothelial carcinoma, I tend to send them to genetic screening, but bladder cancer is also associated with Lynch syndrome, and some of the prostate cancers could also be associated. But I see patients who are presented at a young age, who has other family members that develop the same disease or have a history of colon cancer in other family members or multiple family members, that they have multiple cancers that could be associated with the disease. I will start with a genetic screening for the patient, and if it's positive, I will try to get the family also for screening.
And in terms of presenting symptoms, I mean, definitely I would say the most common is the blood in the urine. In terms of microscopic analysis, how many times you do a full workup for microscopic analysis and actually find cancer?
Yeah, the absolute number, to be honest with you, I don't have it on top of my head, and in my practice, they get to me more the referrals, or I see the patient who has a gross hematuria, so the incidence is higher. The AUA guidelines acknowledge that most of the microscopic hematuриas are not going to have a bladder cancer, so they change and they stratify patients currently to try to minimize the overuse of images, especially in the early population. In my practice as a referral center, most of the patients come either with diagnosis of bladder cancer or already come with an image that suggests that the patients have either upper tract urothelial carcinoma or a bladder tumor.
In terms of biomarkers and urine cytology, I mean, do they play a role in the diagnosis of this condition?
Yeah, so in general, the gold standard continues to be a cystoscopy. Look inside of the bladder, see what's going on over there, and we need to get images of the upper tract. I try to get CT urograms as long as the patient doesn't have an allergy or doesn't have renal dysfunction that they cannot tolerate it. In those patients, if not, I'll do an MR urogram. I do obtain cytology in the patients, but cytology has multiple caveats. Cytology is good for patients that could potentially have high-grade disease. It's not good for low-grade disease. And it's operator dependent, right? So if you are in a center who is seeing a lot of bladder cancer, you have pathologists who are seeing this at a high volume, the sensitivity and specificity of your test may be high, but when you go to a hospital or you're working in the community and you're not working with pathologists who are doing this at a high volume, the value of the test could decrease in a significant way. So I think that's a big caveat for cytology, and we have to be careful about how we use a test from that perspective.
And like you mentioned, most of the time, I mean, I'm still seeing some atypia on the reading, but most of the time I just see no high grade high-grade cancer cells. So, but definitely that atypia, from my understanding, shouldn't be mentioned, and we shouldn't be treating that, right?
I agree with you. Yeah, well, and the other thing is to understand that a negative cytology doesn't mean that the patient doesn't have the cancer. On the other hand, if you have a positive, then we should be looking very carefully to figure out where is this coming from.
Exactly. And like you mentioned, mainly for upper tract malignancy also. So in terms of, let's say you do the resection, you take the patient, do TRBT, patient has no muscle invasive. So what are the surveillance protocol? When do you do intravesical chemotherapy, when you do observation. Explain a little bit more.
Yeah, so non-muscle invasive bladder cancer is a thin line between we don't want to overtreat patients with low-grade disease because it has a financial burden and the burden that implies to the patient all this re-resections and chemotherapies with potential side effects. But then we have to acknowledge that there is a group of patients with intermediate risk, and especially those with high-risk disease, where it's not only that the disease could recur locally, it's that the disease could progress, and that could make the situation of the patient significantly worse. So I think that AUA, NCCN, and the European guidelines allow us to stratify patients so we know which patients will benefit from adjuvant therapies in the bladder. And thankfully, we're starting in an era where we have a lot of good options. In our practice, I think that the key point is TURBT remains a key point for the management of non-muscle invasive bladder cancer. If you're not doing a thorough dissection and to the best that you can, trying to avoid leaving anything behind and be sure that you're studying the patients appropriately. If you're not doing that, patients are not going to have the outcomes that we're seeing in all these randomized trials. And then in patients who have high-risk disease, they need to get appropriate counseling. These patients should get adjuvant therapy in order to minimize the recurrences and progression of the disease for sure.
Yesterday, I did a resection of a patient that had a 86-year-old female. The recurrent infections, I did a cystoscopy. It didn't look like papillary tumor. I took her to the OR and just did biopsy. So it looked irregular, but it wasn't papillary, just like usually your chronic inflammation. The pathology came back high grade, and that's half of the bladder is like that. So yesterday I took her again. I resected. But she's 86, so I didn't want to over resect or go down to the muscle. So in those cases, I mean, it's going to be high grade. You're going to say invasive. At 86-year-old, what do you do with this patient?
Well, I think actually that's a dilemma between what is the age of the patient, the life expectancy, and the comorbidities. Nowadays, we see a lot of patients who are, 86, but they actually have an excellent performance status, and they could live multiple years. And if we don't do an appropriate bladder cancer care, that is going to have a huge impact, not only in life expectancy, in their quality of life. So I think that more than seeing the age, we have to see a patient from every single angle in order to determine what has to be done. So I think that if you have an 86, but a patient has an excellent performance status, doesn't have a lot of comorbidities, then, we should treat this as any other patient in order to minimize side effects and provide the best outcome.
Perfect. So I'll wait for the pathology and then probably repeat the TUR.
I agree.
Okay, Alberto. So what is ctDNA?
So ctDNA is DNA that is released by cancer cells, either when they're replicating or when they're dying, that we are able to capture in body fluids. The most common one that we're using currently is in blood, but could also be done in urine. And it has the capacity to detect, one, the presence of locally advanced disease is the correlationship or advanced disease, or also in patients who already had that the primary tumor was already treated either with bladder preservation or radiation, is a great prognostic factor to predict the recurrence of the disease. The way that it's typically done is actually through a blood sample, but you need to have the primary tumor. And at least the most common one that we use in our practice, they match 16 genes from the primary tumor versus the blood sample, and they do next generation sequence to match and correlate the presence of disease of ctDNA in the blood to call it positive or negative.
So we're talking about in the blood. So urine is not part of this the equation.
So there is some data about starting to use urine. It's not FDA approved. I think one of the companies is coming with a big study right now, and I think the concept makes a lot of sense, but I think that we need to have better studies and take it to a bigger population in order to understand what are the limitations and the real benefits of this. But obviously the concept of having a test that you could diagnose and monitor cancer in a less invasive way is obviously, it could potentially be better for the patient and decrease the burden that associated with the follow-up of these patients.
And we're talking about patients that, had a radical cystectomy, or patients that are undergoing intravesical chemotherapy or chemotherapy in general. Is there a difference?
I think so the data is actually going all around from that perspective. Talking about a case, if you have a patient, 75, good performance status, you do a TURBT in a large tumor, and it turns out that it's T1 high grade, and you do a re-TURBT, there is data, and especially in those patients who already had a BCG, that a significant proportion of these patients are either going to progress in the short term, or they already have micrometastatic disease that has not been determined. And the images modalities that we currently have may not be accurate enough. So, what happens if you do a test that potentially could be more accurate in staging appropriately this patient? So if you have a patient with T1 high-grade disease that is ctDNA positive, okay, the data show that most of these patients will progress or recur in a very short period of time. Obviously, there's a positive in the data over there about what to do. I think in general, the urology community, we all think that those patients need to be treated more aggressively because all of them will progress in a short period of time. But that's kind of one of the limitations of ctDNA, that as we have all this information, the trials and the studies are still a little bit behind.
In terms of, are you saying a patient that has the ctDNA positive, is currently under BCG? One of the options will be extending the BCG for a year, or actually offering early radical cystectomy, for example.
Yeah, so so the data that has been coming up right now is, patients who had high-grade disease, specifically T1 high-grade, that they were treated with a standard approach, meaning intravesical therapies. This patient had a recurrence and progression of the disease in a short period of time. There are not a lot, but institutions that are already establishing ctDNA as part of their protocol, where these patients have been treated more aggressive in trying to cure them. And actually, the question could be further away, because we know that in patients who have muscle-invasive bladder cancer that are ctDNA positive, the chances of getting cured by surgery alone is not that high. So if we, extrapolating is never a good idea, but if we know that for muscle-invasive bladder cancer, in patients with non-muscle invasive bladder cancer, should we offer, combination of systemic therapies and surgery, or systemic therapy with bladder preservation? In my opinion, I think that most likely we're going to go into that route, that direction, that we're going to be more aggressive, but that's where the data is lacking, and we need better studies to understand what's going on in that scenario.
So in terms of, you already mentioned how ctDNA can help in surveillance. In terms of microscopic residual disease after surgery, where does that play a role in that?
Yeah, so I think the first study that shows what this could imply was in the Indigo trial, which was actually a negative trial in patients with a high risk of recurrence after radical cystectomy. They got immunotherapy, and the trial was negative. But when they did a secondary analysis and they stratified by patients who had positive circulating tumor DNA, they found that there was a significant benefit in those patients who were ctDNA positive that got immunotherapy compared to the placebo. So kind of the conclusion is that ctDNA has the power to let us know these patients are at risk of progression of the disease, recurrence of the disease, and if we give them therapy at an early phase compared to just watch them, or placebo, which was a control arm, we could change their progression of the disease and their overall survival. So that's where the prognostic value of minimal residual disease diagnosed by a positive ctDNA could change the game in a lot of these patients.
And in terms of follow-ups or surveillance cystoscopy afterwards, do you think this has the potential to, at least do unnecessary cystoscopies, or eliminate the frequency of doing cystoscopy on patients?
Yeah, so I could tell you from our experience, we have been using ctDNA. Cleveland Clinic, we have been very strong about collecting ctDNA for two reasons. We think that it could change the management of some patients, and then we're using it for academic purposes to understand what the dynamics of ctDNA imply. In patients that we gave neoadjuvant chemotherapy and we get a ctDNA before and after and radical cystectomy. If you are ctDNA negative before radical cystectomy, in the majority of these patients will still find residual disease in the bladder. Saying that the majority of the residual disease tends to be what we call non-muscle invasive bladder cancer. So it will be pathological T1 disease or T2 but low volume disease. So I don't think that current ctDNA in the blood has the capacity to change the use of cystoscopies for surveillance. That's where urine ctDNA, depending on what the data shows, could decrease the burden from that perspective.
And you mentioned that at Cleveland Clinic you've been using ctDNA. I mean, is it a trial or actually you're using it for regular patients?
We try not to change what is the standard of care, okay? But ctDNA has been approved. So we are currently as an institution getting ctDNA for patients with T1 high-grade disease and patients that have muscle-invasive bladder cancer. If it's cystectomy, we get it before. If we think that the patients are going to need neoadjuvant chemotherapy, we get ctDNA before chemotherapy, after chemotherapy, and after radical cystectomy. We follow these patients serially to understand what the dynamics of DNA do and how could this change our practice in the future.
So, Alberto, in terms of ctDNA and high risk, non-muscle invasive, I think you already mentioned a little bit, but what are the trials showing right now?
Yeah, so the one is what we talk about, the in vivo trial, that in patients who are treated with a radical cystectomy, if you have positive ctDNA after radical cystectomy, that is associated with progression of the disease. There is actually a trial, not a trial, but it was a retrospective study that was published about 5 weeks ago, where they check ctDNA on the patients and they compare with images. And then basically all the patients who were ctDNA negative, none of them had a progression of the disease, okay? And then it is important to understand that ctDNA is not only one measurement, okay? The ctDNA could change over time. And yes, over time, some of these patients will become ctDNA positive. And typically, a ctDNA positive will become a positive image about 3 months later. So it has the capacity to predict the recurrences of the disease in order for potentially offer therapies that could change the outcomes in the long term. And that's where the trials have to show that, okay? On the other hand, trials like the Niagara trial, which is a trial where they did gemcist plus durvalumab as an immunotherapy, and as a secondary analysis, they check how these chemotherapies and immunotherapies could change the dynamics of ctDNA, and we could see how the patient responds, and those changes in the dynamics of the ctDNA correlate with recurrence in the survival outcomes, pointing out that ctDNA is a huge predictive factor that I don't think that is going to eliminate images in the future, but most likely is going to decrease the amount of images that we're going to have to be doing as the patients are negative or positive.
And in terms of, you mentioned something very interesting. So let's say if you're doing X chemotherapy in this patient and you're following that ctDNA and you're not seeing that it's going down as much, in those cases, I mean, what would be the idea? To change the chemotherapy you're giving to the patient?
Yeah, I think that's the biggest problem that ctDNA has right now, that it's giving us all that information, but the trials have not been designed. And I think as a urologist, a lot of us think what we think is right or wrong, but we don't have level 1 evidence to understand what we should do in that setting. Thankfully, actually, there are multiple trials going on right now, so we could understand what to do exactly in those scenarios.
Good. So you mentioned a couple of trials. So you mentioned the InVigor, the Niagara trial. What other trial is out there? I think you mentioned the Tombola.
Yeah, so there are actually, if you look into this, there are a lot of trials that are going on in this scenario, and they're being used by medical oncologists, they're being used by urologists, and they're being used also by the radiation oncologists. There's a recent proposal that, if you have muscle-invasive bladder cancer, but you are ctDNA negative, do we need to give chemotherapy to those patients, or could we go upfront to surgery and minimize the burden of the chemotherapy. So that's something that we should be seeing in the near future. The same thing for bladder preservation. Typically, who is the patient who could benefit from bladder preservation, or where the data has been the strongest, are the patients who are really T2, they have a complete resection, the disease is unifocal, and the tumors are relatively small. The kind of the thought process that you could imagine over there is that the outcomes are going to be better in those patients who are ctDNA negative. Most likely the radiation will offer you a better outcome in that setting compared to the ones who are ctDNA positive. So the value of the ctDNA may allow us to personalize treatment and understand when do we need to intensify the treatment in these patients, or when can we go straight to radiation or surgery and avoid the side effects of these systemic therapies.
So you mentioned radiation to the bladder. What patient will you do radiation, or you prefer to give radiation versus surgery?
Topic that debates, especially in the urology community. I train at Mass General, where we were doing a lot of bladder preservation at Mass General. So bladder preservation by the guidelines has, in appropriately well-selected patients, it could be as good as radical cystectomy. But I think the message that we have to pass to the community, not only to the urologists, to the radiation oncologists, is this is in a very well-selected population of patients. And this is basically independent of the age. And as long as we are following those criteria, and those are the criteria that we basically talked a couple of minutes ago, which is T2 disease with a unifocal disease, in ideally no CIS, no hydronephrosis, that you do a complete resection. Those are patients where the local recurrences of this muscle-invasive bladder cancers are relatively low, and they could benefit from bladder preservation. And to some degree, there could be a better quality of life in some of these patients while you preserve the bladder. But at the end, it is all about selection criteria, and it goes to the same principle that the transurethral resection of the bladder tumor is critical in order to select and be sure that these patients could potentially benefit of this treatment.
And in terms of clinical implications of the ctDNA, I mean, where you see this is heading in terms of, you already mentioned that we don't maybe in some cases do more bladder preservation, but do you see, or be more aggressive? Where do you see this heading?
Yeah, so I precision medicine has 2 points of views. One is, like, let's identify the genes so we could target that. But the other part of precision medicine is which patient needs what, right? And ctDNA actually has the capacity to do both. It has the capacity to let us know potentially which patient can we avoid less aggressive or more aggressive treatment options. But ctDNA actually has the capacity to identify mutations that could potentially target therapy, that we could target therapies in the future. So we already know that ctDNA is a predictor factor, okay, is associated with recurrences of the disease. It has the capacity to personalize treatments, but that's where the trials have to prove the benefit and how can we use that information in order to provide better patient care.
And I'll try to extrapolate this to European treatment for bladder cancer. We know that they're trying to preserve more, do more bladder preservation. Are they using already ctDNA in their process of diagnosis?
I don't think as a standard of care they're using ctDNA, okay? Which is kind of the same as in the US. Big academic institutions are into the ctDNA right now, and they recognize the prognostic factor associated with ctDNA. A lot of these studies that are common, like the INVIGO trial, they have patients from Europe where they have been using ctDNA from an academic perspective.
Okay. So yeah, so definitely all those trials that continue to come up will give us more information, and hopefully better use of the ctDNA, because like you mentioned, I mean, it's a great tool. So Alberto, definitely we have covered a lot. You mentioned precision oncology. Where do you think, I mean, do you want to add anything else in terms of precision medicine?
No, I think that we covered both points. I think that this is going to be the disruptive technology, in my opinion. I think it's going to let us know when to be more aggressive, when to be less aggressive. But even we're starting in an era for non-muscle invasive bladder cancer where this technology may have the capacity to identify some of the mutations associated with the tumor and tailor the treatment for the patients as the trials are coming. And that could have a huge impact in the patients, and it's most likely going to provide us better outcomes in the long term.
And Alberto, in terms of financially, I mean, is this something that is very expensive?
So, it's FDA approved, it's Medicare cover for bladder cancer. It's not a financial burden for the patients currently, but obviously as a disrupted new technology, it could be expensive for sure.
So you said right now it's under Medicare, so they approve it, so it's just a matter of probably getting all the check marks so it gets fully approved. And are there many places doing it or just some specific labs?
So there are a couple companies doing this. We're in our institution, we are working with Signatera, trying to collect the data very robust with them. And the process is actually quite simple. And they go to your house. And right now we have a process that, they go to your house, they get the blood sample, and then every 3 months we're getting blood samples in order so we could follow the dynamics of the ctDNA, and we have a longitudinal follow-up and understand what to do with this test.
Excellent. Alberto, I mean, we have covered a lot. Any final messages?
No, I think that we're entering in an era where personalized oncology, I don't think it's going to be the future. I think to some degree it's the present. I think with that, we're going to be seeing a lot of changes in the way that we diagnose, that we stage the disease, and for sure how we follow and how we tailor treatment for our patients. Hopefully the trials are going to prove all these concepts.
And right now, your institution, I mean, if a patient, when do you use, for example, hem-onc? I mean, our urologists should be the gatekeeper of the bladder cancer, and then we should send the patient to the hem-onc. How does it work in Cleveland Clinic?
Yeah, so like anything that is non-muscle invasive bladder cancer is primarily treated by us, and I think that's a standard around the country, unless you're working in a specific trial. For muscle invasive bladder cancer, even if we think that the patient may either is not a candidate or may not benefit from the chemotherapy, we still send patients to the medical oncologist, and we do it in a multidisciplinary fashion. And kind of the order of some of these tests is, whoever saw the patient first is typically ordering. If we give neoadjuvant chemotherapy, typically that follow-up is done by the medical oncologist.
Because sometimes, I mean, at least I'm urologist of the community. Sometimes when we start talking about genetics, things like that, then we incorporate a hem-onc so the patient has more details. So we don't spend talking to the patient a lot. So, but definitely, I mean, we shouldn't continue sending those patients to the hem-onc. We should be part of this process and definitely be on top of it and know the new things that are coming to treat better the patients.
Yeah, well, the data is coming that we're starting to use it at early phases. As the data is stronger and potentially we standardize this, it's not like we're going to be forced. I think that's just the new way that this is going to be work out, and we need to get used to work with these tools.
Exactly. Well, Alberto, it was a very interesting conversation. Thanks for your time and thanks for being BackTable.
Thanks, Jose. It was a pleasure to be with you today.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.